thank the organizers for giving me an opportunity to talk today about our data. I mean, I think the title of this meeting in 2008 was Pediatric Immunotherapy, Progress and Challenges. I think it's really amazing, you know, sitting in the audience today and realizing that there's certainly been a tremendous amount of progress, certainly in the clinical arena, but I think we certainly realize that there's a lot of challenges that we still face in terms of you know, moving this forward into other targets, other tumors. You know, my lab is certainly heavily involved in trying to optimize adoptive cell therapies for leukemia. I've decided that's a bad idea after watching Mike Jensen's presentation this morning, because there's no way that we can compete with that. But what I'm going to do now is I'm going to address a very, I think, simple question, maybe to a certain extent, provide some very preliminary data to that in that regard, you know, that Steve mentioned, which is, you know, what we have to know is whether or not CD19 and ALL are really going to be unique. Although there's a lot of very promising preclinical data, what I'm going to try to share with you today is maybe some insights as to whether same tumor, ALL, as Mike alluded to earlier, maybe the poster child from the standpoint of response to CAR therapy, but a different target, a target that's similar to CD19 but different. And I'm going to share some of the very preliminary results from that clinical trial. I'm going to start, though, sort of by talking a little bit about a story about the development of the CD22 CAR that really took place in Crystal's lab. Rimas Arentis doing most of that work. And what it illustrates is that making new CARs is not simply plug and play. You know, you take an scFv, it binds, you stick it into a CAR construct, and voila, you have a new CAR, and it works beautifully. Because that was certainly not the case in the development of this CAR. I'm not going to talk much about this slide since Andre did such a wonderful job talking about CD19 negative relapse, but this is one of our xenografts that we've developed from a patient that was referred for CD22 immunotoxin and then eventually got CD19 CAR. Came in CD19 positive, got the CAR, and relapsed with disease that had completely lost CD19. But what we have found is that in all of these patients, we have seen that, and this has been expanded since this time, we've seen retention of CD22 in the CD19 negative relapses. That seems to be a theme that we're seeing. Possibly some lower site density on the CD19 negative patients, but I think that remains to be seen. So what is CD22? It's a member of the Siglec family. It's different than CD19 in the sense that it's much larger in the extracellular domain. It is expressed on normal B cells beginning at the pre-B cell stage, and it's really a negative regulator of the B cell signal. Andre can talk more about this and is certainly more knowledgeable about this, but it's involved in the development of a regulatory B cell subset. We know that it's a clinically viable target in ALL based on data from immunotoxin trials, inotuzumab, which is a conjugate with calicheamycin, and moxetumomab that Alan Wayne really began all the work on at the NIH, conjugate to Pseudomonas exotoxin. But with both of those conjugated antibody constructs, there were remissions that were observed of 25 to 50% of patients across those two trials. So we know that CD22 is a good target. So, I mean, the obvious question, given that the moxetumomab agent was developed by Ira Paston at the NIH, was to simply take that and make a CAR. It's a very high affinity binder to CD22. In fact, it had been optimized by Ira Paston based on rational mutation to be higher affinity than the parent binder, BL22. And so Rimas and Walid, who was working with Rimas at the time, simply took the scFv and stuck it into the CAR construct that was being used for the CD19 trial at the NIH. And lo and behold, it did nothing. Even though it bound. And so they went back to Mitko Dmitriev, who is a very talented individual at the NIH who has a phage library that has human B-cell antibody sequences and had screened for a number of other binders, and there were these other binders that were actually lower affinity and therefore not really used for the development of the immunotoxin. And so they pulled a couple of those binders out of the freezer, so to speak, and stuck those into the CAR, and lo and behold, this binder M971 worked beautifully as a CAR, and this was published in 2013 in Blood. And that was associated with enhanced persistence of these CAR T cells in these preclinical models. And this is a NALM-6 model that we got from Steve Grupp's group at the University of Pennsylvania. And so it turns out that there had been a paper published by Oliver Press's group from Seattle that had already sort of figured out probably what is the story here, which is that where the scFv binds in the extracellular domain is very important. And so it turns out that HA22, very, very high affinity, but it binds membrane distal. M971 binds membrane proximal. And what Ollie had done is to take this epitope, move it down here, and could make this CAR work, basically. And so really what matters is not the affinity, although there is possibly some contribution of that at lower site densities, perhaps, but where the scFv binds. And so we then, with Waleed in my lab, went to look at whether we could improve on this somewhat, because although it looked like both of the different constructs that we were working with two different co-stimulatory domains, either CD28 or 4-1BB, were quite active in vitro, what we ended up finding was that they behave differently in vivo, and as has been seen in, I think, clinical trials now, people agree that a 4-1BB co-stimulatory domain results in enhanced persistence, and in fact what we ended up finding was that the responses in this NALM-6 model were durable then. And so this is the construct that we ended up taking into the clinical trial. Normal tissue expression, this is data from the Protein Atlas. It's actually interesting. If you look at this, the blue is where it's expressed. If you look at 19, it's actually pretty scary. I think if you looked at this initially, you probably wouldn't take 19 into the clinic, and there's probably an important point there. 22 actually is much cleaner. This is all lymphoid tissue shown here, and this is appendix. We ended up working with Paul Sorensen, who had has a beautiful tissue microarray through the Stand Up to Cancer St. Baldrick's grant mechanism, and confirmed this in this tissue microarray screen. You know, during the time that we were developing this clinical trial and went to the FDA, they weren't happy with that, and this was actually something that was alluded to yesterday. They wanted to see some sort of functional screen to show that the CAR T cells weren't active against normal tissues, and that's hard because you need a viable target, and there aren't a lot of viable non-malignant cell lines. And so what Haiying actually did was to look at a panel of tumor cell lines, but then also looked at iPS neural stem cells and iPS cardiomyocytes to look for cytokine production with active CAR cells in culture. And this is what we ended up doing to address that concern that the FDA had. This CAR is active against CD19 negative xenografts, as shown there, and I will actually just move on to the trial design. So what we ended up doing was we opened the trial early this year. It's a standard phase 1 dose escalation, a 3x3 schema. We have a planned expansion cohort at the maximum tolerated dose. The dose levels are shown here. We started at 3 × 10⁵ per kilogram, and I'm going to show you data from that cohort of patients today. We're now on the second dose level, 1 × 10⁶. And we have an opportunity to expand one more time, at least. And then once we find an MTD or a dose that we're happy with, we will then expand. And we've decided to have 2 groups in the expansion cohort, one CAR-naive patients and the other patients that have previously received CAR. We heard earlier about immunogenicity and T-cell responses to mostly the scFv. But as Mike alluded to, I think some of these responses may actually be targeted at other regions of the CAR, at some of the junction regions between the different constructs. And so I think it will be important to have that cohort in the trial. Eligibility is shown here. It does include both children and young adults. Offline discussion about the challenges of getting a first-in-human trial with a pediatric group on it through the regulatory agencies, but we were able to do that. The schema is shown here. It's a very simple trial in the context of currently ongoing clinical trials. It's an intent-to-treat trial. All patients receive the same preparative chemotherapy, actually lower than what has been shown in some of the earlier presentations. 3 days of fludarabine, a single dose of cyclophosphamide, 900 milligrams per meter squared. This is the same regimen that Trey Lee used in the CD19 CAR trial that he published in Lancet. We give the chemo, we make the cells in 9 days, and we infuse the cells either fresh or cryopreserved, depending on when we initiate the culture relative to when the patient starts therapy. And then the patients are evaluated for response and toxicity. So this is the summary so far in the first cohort. We enrolled 6 subjects. We had to expand by 3 patients because of the development of grade 3 diarrhea that was self-limited in the first patient, in the second patient in that first cohort. We actually amended the trial to exclude that as a DLT. As long as it resolved within 72 hours, that patient was having cytokine release at the time that that diarrhea developed. We haven't seen that in any of the other patients, even after we modified the trial. There's been no dose-limiting cytokine release syndrome, and from a feasibility perspective, we were able to generate cells meeting the release criteria in all of these patients. In fact, the lowest transduction efficiency was 30% in any of the products. So this is a summary of the patients in the first dose level. All of these patients had received previous CAR therapy. All of these patients had previously undergone a transplant, so a very, very challenging patient population. Just for interest, here's the site density for CD22. Average for 22 is about a log, maybe a half a log lower than CD19. This patient's interesting, a site density less than 1,000 copies per cell. This is actually a quantitative site density by flow cytometry, and that patient ended up having a week of fever with cytokine release syndrome with that site density. He had no non-malignant B cells. He was BCL aplastic when we treated him. We have seen certainly evidence for CAR expansion in the second and third patient. I'll show you a little bit more about these patients in a moment. We saw CRS in 3 patients. I will tell you that we had 1 patient, and I'll show you in a moment, had an MRD negative complete remission. The next 2 patients had stable disease, although there was certainly evidence of clinical activity in patient number 3 that I'll show you in a moment. As was mentioned earlier, we did see evidence of CAR T cells in CSF in at least patient number 3. So this is the second patient treated on the trial, showing the expansion of the CAR T cells. Interestingly, although Trey has seen expansion starting as early as day 7, we have not seen, at least in this dose level, evidence for CAR T cells on day 7. Instead, we tend to find it on day 14. Again, this patient went on to have an MRD negative remission that was sustained at 2 months. There were 19% CAR T cells in the bone marrow at 2 months. Unfortunately, this patient went on to relapse. This was a CD19 negative patient, and at relapse, interestingly, this patient re-expressed CD19 after receiving the CD22 CAR, although much lower site density. So just to complicate the field even more, but we can talk about that more later. But this is the bone marrow on this patient pre-CAR, showing TDT positive cells 8 weeks post-CAR, absence of those cells. And so evidence of activity for sure. And this is patient number 3 on the trial. This patient had very high burden disease, greater than 90% blasts, had circulating blasts, got the preparative regimen, some reduction, and then started to blast off after CAR infusion. We got worried at this point and then had a reduction in CAR T cell, circulating blast shown here. And at day 14, at this time point, 75% of his circulating T cells were CAR positive. Unfortunately, this patient then had a subsequent rise in his blast, and so by day 28 didn't meet official designation for response, still had CD22. None of these patients have relapsed with CD22 negative disease so far. And so this is just showing sort of a composite of the expansion data, at least in the patients number 2 and patient number 3 in the various compartments. Again, as I mentioned, we have seen evidence for CAR T cells in patient number 3 in the CSF. We certainly see CAR T cells in the bone marrow. It seems to be sustained, at least in patient number 2, out to about 2 months. And so, you know, I think preliminary conclusions at this point. I mean, we know that it looks like the CD22 CAR is active with no unexpected toxicity. We've been able to make cells in all of the patients enrolled so far. All of these patients were obviously a challenging group in that they had all received previous CD19 CAR and multiple transplants. The relative potency, though, I think, of the CD22 CAR relative to the CD19 CAR, I think at this point just remains to be seen. The data is just too early. And so with that, I'll just acknowledge all of the folks that did the work. As I said, I mean, the CAR was generated in Crystal's lab. Remus Arentis did the work with Walid Hasso. This is my group that did a lot of the preclinical development of the CAR. The cells are produced by a very talented group in the cell processing section in the clinical center. We have certainly been collaborating in all of these trials with Jim Kokendorfer in the surgery branch. And as I said, a lot of the models that we work with in the lab were generated at Children's Hospital of Philadelphia. So with that, I'll stop, and I think we'll take questions at the end.